Very briefly introduce our lovely speakers. We have Danielle Lowe and Christina Ramirez from Shields for Families. And as you see, the topic is becoming a certified community behavioral health clinic, integrating care for African American pregnant and parenting women and their families. And just so everyone knows, all of these materials will be available on Wahova after the event, and you'll have access to the PowerPoint and the recording from today. So I'm going to let Danielle and Christina take it away.
Perfect. Well, thank you, everyone, and welcome. We appreciate you selecting us to spend your hour with us. If you have any questions throughout our presentation, please feel free to raise your hand. We are all for interaction and communication, what's best for us all to really learn from one another. But as stated, I'm Danielle Lowe. I'm an LCSW. I'm the Behavioral Health Services Director at Shields for Families. I have been fortunate enough to work at Shields for 22 years as of this year. So I'm very excited, love what I do, love the community we service. I am an LA native, Inglewood and Leimert Park. I am a mother of 3 wonderful children, 20, 14, and 7. And I identify as biracial. I am Black and white. And so saying that just because we come with many different layers, many different intersects, and they really impact our lives and our profession and how we view the world, and definitely a huge part of what we will be discussing today in our presentation.
Thank you. I'm Christina Ramirez, also with Shields for Families. I'm the administrator of our mental health services. I have been with Shields for almost 10 years. Also a mother of 2 little girls. I have a 3-year-old and a 1-year-old. So, you know, it's always a little crazy around here. My children are biracial. I identify as white. And we're just happy to have you all here. We're going to get into talking about how to support mothers and families in general. And so welcome and happy to have you here. Just some community agreements as we get going. We are going to be talking about systemic racism. We're going to be talking about disproportionality in systems. And so just listening to your body, understanding if you are feeling triggered, we understand. Turn your camera off. You can private message us if you'd like, and we can provide some support. Really trying on the perspective of the person speaking. Danielle kind of touched on it, but we come from so many different backgrounds. I also am an LA native, forgot to say that, from Inglewood too, so we're representing that area hard, but we appreciate you all for being here. It is okay to disagree. If you disagree, please let us know. Let's talk about it. Just not okay to blame. Practice both and thinking, leaning into that a little bit of discomfort as we talk about this, and then acknowledging intent versus impact. Just we're all here because we really value prevention. And so how can we support families through that? So if we're all okay with that, again, you are free to interrupt us, raise your hand. We are very much in-person people, so just let us know, interact, and we'll be here. Some objectives for our presentation is to be able to identify at least one impact that systemic racism has had on engaging African American pregnant and parenting women into behavioral health services, identify at least 2 culturally and/or trauma-informed practices that increase access and engagement into behavioral health services, and develop an initial understanding of the federal certified community behavioral health clinic model, 2 benefits of implementing the model within your agency or practice. Hopefully by the end of that, we've accomplished all of that.
Thank you. And then some key terms that we're going to go over, and just so you all know what we're talking about, we will say FCT, which is family-centered treatment. So our agency really functions through the lens of family-centered treatment, where we service the entire family as they come to us. So really focusing on that entire support system to support that systemic change and overall generational impact to support just community change and lifelong change. Cultural humility, again, a lens that we provide services through, just that we encourage our staff, our participants to always be lifelong learners, really focusing on the fact that we can never know everything about anyone's culture, and we need to continuously be open to learning and growing and adapting our practices as we continue to evolve as a community. And BIPOC, just really focusing on Black, Indigenous, and people of color. So we'll use that term throughout our training as well.
All right, so we're going to give a little bit of the historical context just to talk about Shields for Families, how we got here, and then how we are where we are now. So sort of setting that foundation, in the early 1970s, Nixon declared drug abuse as America's public enemy #1. So all the funding during this time, as I'm sure many of you are aware, went into criminalization, incarceration, law enforcement, very little focus on treatment for individuals that had substance use disorders. And then that just continued really with the Reagan administration coming in with the Just Say No campaign with First Lady Nancy Reagan, focusing on it's your own willpower to just say no to drugs. And if you didn't say no to drugs, then there's like a personal flaw that you had. So this idea then translated into children being removed from families at a higher rate, just with the view of like children were victims of the parents who couldn't say no to drugs, and the state had to step in to prevent and to protect the children. And during that time, then children didn't get the treatment that they needed. They were in foster care for lifelong and into all of their childhood without the treatment, aging out of the foster care system, and just perpetuating this cycle of trauma, really focusing on criminalization of substance use versus treatment.
Absolutely. And so what we see here is really the impact of those systematic thoughts and beliefs and practices from the war on drugs. So this is a very old school graph of, what the child welfare system looked like in the late 80s, early 90s. And so we see this dramatic increase of detainment. And specifically, really, when we look at South LA, you see the detainment increasing for African-American families. And so all of those practices and those beliefs that Christina really just discussed really shows the clear reason and why we see the destruction of families. There was displacement into either the child welfare system or into the prison system, and we are still seeing the residual impacts of that today. But as a result of this, the war on drugs, Shields for Families slowly made its way into the world in 1990. And so, next slide, please, sorry. And so, I don't know if it's me late. We're getting used to this, y'all. We like to be in person. And so in the 1990s, these are our three amazing founders. And so Dr. Catherine Eisenhower, who is in the middle, she worked at the county, and her and Norma M. Toomey, who is with the white beret on her head, they worked at the county together, and they really saw directly the response of the child welfare system and how it was directly impacting African-American families, specifically at the time in South LA. And then Dr. Excelina Bean, she was head pediatric doctor at Martin Luther King Hospital. And that was the highest utilized hospital within South LA at the time. And so she was also seeing directly the amount of children that were prenatally exposed to substances, and as well, the response of child welfare system going to those hospitals, detaining those children at birth with no supports in place to really reunify the family. And from there, that's really where we saw the introduction of Shields for Families. And so Dr. Catherine Eisenhower, actually, Shields for Families was her dissertation, where she was like, let's create a model where the entire family can come and receive services together as a unit. And through providing those supportive services, we can prevent child welfare involvement and then support families with reaching whatever they've identified as their goals to stay together and receive the treatment that they require for either substance use or those other mental health disorders.
Yeah, so the family center treatment was sort of getting some traction nationally around this time, but Shields really adopted it, and just that's our model throughout every program that we have. And it is different from the traditional treatment model where the individual with substance use disorder in traditional treatment will be removed from home and go away to treatment and then re-enter back into the home after the 90-day model and sort of expected to be sober and maintain their sobriety when their environment hasn't changed at all. And so the family-centered treatment model is totally different from that, in that we want the whole environment to come into treatment and to get all the supportive services that they need. And so the whole family is welcome into treatment. With that model, we have about a 70 to 80% success rate for co-occurring and SUD treatment versus the national average is only 25% in that traditional treatment model. So we see that it's imperative to really involve the family and the community in this treatment work. And then a couple key components is that the family can be whoever they want to identify as their family. So many times it's biological, but a lot of times it's pastor or a coach or a friend or a neighbor. Whoever they want to involve is who we're going to involve. And then every single person is incorporated into that treatment model, and just collaborating on what they want to accomplish. What are their goals? And then how can we support the family in reaching their own goals? Yeah. And then SAMHSA did research on this model in 2007 to just show the positive outcomes were in many different layers. So the individual had positive outcomes in changes in their mental health, decreased substance use, increased employment, and decreased criminal behavior. Positive outcomes were identified in this study with relational outcomes. The parent-child relationship was improved, family stability improved, improved attachment, and then even systemically, just outcomes, increased employment means increased tax revenue, decreased criminal recidivism means a decreased cost to the criminal justice system, and so on and so on. So really, it does show, the research supports that on many layers, the family-centered treatment model is very effective.
Thank you. That was our quick little journey. And so definitely we like to go over some of those historical stigmas and content because it really does shape the why we're doing what we're doing, why we're reacting the way that we're reacting, why families are dealing with all the barriers that they're dealing with. So we have to consider those historical contexts, and also so we don't make some of the same mistakes that we've made in the past, and we don't miss what's actually going on within the community, within our systems. And so it really gives us that outlook to the why and what we still need to do as far as work. So for those of you who are not from LA County is huge. There's about 10 million people in LA County alone. We service SPA 6, which is the South LA area. And so we have about 1 million within SPA 6. So we're quite big. And so really just wanted to point that out and also point out some of the demographics. I do want to highlight that within the SPA 6 community, so LA County as a whole has about 7% African American population, but within SPA 6, 30% of the population identifies African American. So that's a very large percentage for us. And so this is why a lot of our work is still focused and targeted to African American families, not only because of the population, but because, as we all, I'm sure, know, Indigenous and African American individuals are still disproportionately represented within the child welfare system as well as the criminal justice system. And so, of course, our lens, aligned with a lot of preventative work, is that if you fix the system for those that are most vulnerable, it will correct and fix the system for all that are involved in it. And so we are definitely, throughout our training, our presentation, I should say, highlight African American families and our work there. We can go to the next slide.
Yeah, and then really the disproportionality is also prevalent in the behavioral health system. So 2018, SAMHSA did a study to say 16% of African Americans reported having a mental illness, 22.4 of those reported a serious mental illness. And then in 2019, suicide was the second leading cause of death for African Americans within that TAPE population. and it's continuing to rise throughout the years. This is a graph just to show throughout the years on every age demographic, there's an increased need for major depressive disorder treatment in African Americans. So it's just continuing to increase over time and get very, very close to the national average. But there's a problem in the way that we're providing treatment, because we see that for the most vulnerable, our substance use adolescents, for example, only 88% of them are involved in treatment. For co-occurring individuals, only 91% are involved in treatment. And so that's really showing that we haven't set up treatment to include African American families in their children. And so it highlights that we need to adjust our behavioral health systems so that we can include populations that over time have an increased need.
And you can tell we left some data around here. And so just continuing off of that, what Christina was saying, really our systems, the way they've been set up, there's still a lot of work that we need to do, because we still see maternal mortality rate, infant mortality rate specific to the African American community is still very high in comparison to every other counterpart. And so what we wanted to do and what we continue to do as Shields is try to address, those barriers, those systematic barriers that we're seeing that are related to all of these inconsistencies and disproportionality within all of our systems across the board. And so continuing on with that, so child welfare. So a lot of our work and continued work was really around child welfare system and looking at those areas that we need to improve in order to reduce those disproportionalities. And so something that we definitely highlight with our families is that there is still an over-involvement with the child welfare system. And most of the time it's due to not having services that are culturally and trauma informed that can really engage and provide that overall support for our families. One stat that is not on here, but that we definitely like to highlight, is that 1 in 2 African American families will have some type of involvement with the child welfare system by the time they reach the age of 18. And so for us, that means that there is a problem with the system, and also there is real justification of why families, specifically African American families, fear the system, because it is the reality that unfortunately sometimes when individuals just need help, they're getting put into systems unnecessarily instead of receiving the preventative supports that they need in order to be successful.
Yeah, so the Shield's call to action is really just to do that, to provide culturally responsive, trauma-informed mental health and substance use services. And we just understand it's critical to include the population that we're hoping to target. It's just essential with making sure that our services are aligning with the community. And so with that, our very first program was developed. This program started in the early 90s. And it was at a different location, used to be in the parking lot of MLK Hospital, and now is at this building. We're located in South LA. We have about a $1.5 million budget. We have capacity for 40 women and their children. Right now, the demographics are about 70% Latino, 28% African American. And we are seeing a much younger population than usual. It's now about 28 to 35 years old, with a top diagnosis of methamphetamine and alcohol abuse. But this is our Genesis program that really is a one-stop shop. So the building is designed so that the women can attend treatment, and then our Child Development Center is attached to their treatment facility. So they can see their babies throughout the day, change diapers, feed meals, all while they're in treatment. And then the treatment schedule is meant to mirror like a traditional work schedule, where you come in, you check your children, you make sure that they're in their childcare supports, and then you're attending from beginning to the end of the day, you're in program. Embedded into your treatment schedule, it's really integrated services. And so in your treatment schedule, you have your parenting classes, you have your family reunification to make sure we're meeting court requirements. But you also have embedded in the treatment schedule, we have a 5 Keys partnership where they provide education support so that families can earn their high school diploma. And then also Jericho will do, if you come in with some college or you already finished high school, then you can get some vocational training and additional college classes. We also provide transportation. So we have van drivers that will pick you up and your children, and they will bring you to program if you need that, as well as transport you to all your medical appointments to make sure your children are meeting their medical appointments, but also you get the medical care that you need. It really is a one-stop shop for families.
Perfect. Well, yeah, she really covered all of this and these next points on this slide. So really what we're targeting to do, of course, through that lens of really supporting families with not becoming involved in the child welfare system, really just building out the model to surround and create those avenues to support with reaching those goals. And so that's just really what we continue to do. And part of that, and we'll talk more about it later, but part of that is really guided by our participants. So we have a consumer advisory board and that meet weekly, which is also a part of their treatment. So really mirroring what a traditional student body would look like within a high school. And they represent their programs and they give us direct feedback about what they need, what they don't need, what we need to do better, which they always love to do. So really just guiding and shaping what we need to go after. And so that is really been the driving force behind all of our additional programs. Right now, Shields has about 38 different services provided, services and programs for our families. But again, it's really because of what our participants said that they needed in order to be successful with reaching their ultimate goals for their families and for themselves individually. And so like Christina did very well, one-stop shop model. If you are a mother and or a father and you have 5 children and I have to go to 10 different buildings to receive my services, the likelihood of me going is going to be slim. You may catch me the first appointment, but after that, I'm not taking everyone else with me to all of these different locations, especially if I'm dependent on public transportation. And so we saw that engagement and or lack of engagement or quote unquote resistance really wasn't with our participants. It really was with the system and us not being willing to go to our families to provide those services to them in the way that best supports them as a whole. And so really shaping and framing the model around what the participant needs versus what we needed as providers has been key in successfully, supporting our families with no longer being involved with the child welfare system and or if they come to us with child welfare cases, successfully completing and closing those cases.
So just some key components for the family-centered treatment model. First of all is at any of our locations, they can walk in and they're going to get a screening. And so families will be linked to what programs they need and what they kind of qualify for, and then go from there. If a family comes in and they say, I want treatment and I want to start today, they'll be transported that day from whatever site they're at and then linked to treatment so they can start that day. Once they get to the program, they'll receive a much more thorough assessment. So we use the ASAM for SUD, and then we use a biopsychosocial for mental health. Then they receive their therapy and their treatment on site. Family support services. So we have a DCFS liaison, and we have an individual that attends court appointments with them if that's needed, as well as partner services. Like if your partner comes in and also needs treatment, we have a co-ed facility that they can attend treatment at. They can also just participate in vocational training, housing support, really anything that the partner also needs. And then aftercare, once you graduate, you're connected with our large group of alumni that really wrap around you to make sure you're still connected and you still have support long term. And so if you ever needed anything, you still have a community that you're attached to, and that's run by alumni of our Shields program. So these are some core components, but really the foundation is just to see the individual and the family in front of you as humans. They have many, many different layers that they're coming in, many different intersectionalities. And so they're not just an individual with a substance use disorder, they're mothers, their children, their wives, daughters, all of those different intersectionalities. And so when they first step into our treatment site, the first question they're going to get is, do you want some coffee? And we love our caffeine at Shields. And so we want to offer it to the family as just, do you want some coffee? I see you have some children with you. Are you all hungry? And then we provide a meal if they need it. And then let me introduce you to Miss Gwen. She can kind of watch your children. You can see where they are so that you feel safe and we can really focus on what we need to do in this appointment. So first and foremost, just meeting those initial needs helps to decrease that barrier and just build trust in the relationship right off the bat. And then kind of building on that, we talk early on in the relationship about our prevention efforts so that families feel safe and can build trust in the family to just really, we're not here to involve you in another system. We're here to help you get out of those systems so that you can focus on what you need. And it really does decrease a lot of the barriers and just help families to really feel safe when they enter our room.
And so with that, we just continue to, of course, areas for growth. What can we do? What are services? What are practices? What are policies that still need to be updated and or adapted, changed in order to support our families? And what we saw was just the communication between systems and us aligning as systems with one another. And so CCBHC is a model. And so we were fortunate enough to receive a grant beginning in 2023 to begin our journey to become a CCBHC model. And so there are 9 core services with the CCBHC model, but really what it focuses on is the whole person, ensuring that everything within that individual and or family is being addressed and or serviced. And so as part of this, really that communication between systems has been key for us, a key area for growth and learning. And so we've partnered with a lot of medical providers within our community to ensure that there's some cross-training going on because we're focusing on African-American families and mothers. Most often, that first interaction with the child welfare system happens within labor and delivery. Historically, that has been the case within our community, and it continues to be the case as well still today. And so for us, it was really identifying safe medical partners, providing training to them and all of their staff, and them partnering with us, learning about our community, learning about demographics, learning about preventative safety and support plans in order to really reduce that innate reaction just to call child welfare system, but rather call community partnerships in order to come in and provide supports to families. And so with our CCBHC model, we have really been given the opportunity to provide supports to those larger systems to ensure that families are ultimately supported and again, are not being unnecessarily involved in child welfare system. And then of course, with those added supports of mental health and other supportive services, reducing that criminal justice involvement as well. And so these are the 9 core services that we really see, again, just highlighting the importance of culture and trauma, being aware of that and incorporating that as part of treatment. That targeted case management, like Christina said, I'm not doing an assessment if I'm hungry. I'm not doing an assessment if my children are running around, if they don't have a clean diaper or a changed diaper. And so really doing all of that upfront case management to support the individual in front of you, again, putting their needs, putting their wants first, and then worrying about our paperwork afterwards, right? Because once we engage, once we're able to provide a supportive space, everything else really just comes naturally, and our families are really open once they see that they can actually trust us. I think one of our LIV experts really said it earlier, like listening to me, hearing my requests, hearing what I want and what I need. was key, because I had disruption in relationships before. And so knowing that I can trust that provider was really key in me being able to go through this journey, this difficult journey. And so that's really, CCBHC definitely highlights the ability to be person-centered, client-centered, family-centered.
So I'm going to kind of skip, but we had already behavioral health services in place across the lifespan. Something to highlight that fits within the CCBHC model that we did really have to like beef up as part of the model was our crisis response team. And so we have a 24/7 crisis response line, and we have 11 LPS designated staff. And so we alternate coverage of that line throughout the year, really. And then neurofeedback, we offer that at our schools and at all of our treatment sites. It has been shown to decrease cravings across your like recovery journey. And so we offer that as part of our CCBHC model. And then I'm going to give it to Danielle that kind of will talk about our first step in the CCBHC process.
Perfect. Well, with every first step of anything, we have to do a community needs assessment. And so that is really where we started, just partnering with providers as well as consumers and community members to really identify what are the needs of the communities. Of course, as being workers within the community, we have our own perspective. So it was really important to gather that from all of our community members across the lifespan to say, okay, what do we need to target? Again, our participants know where to go get services. They know who treats them nicely, who do not treat them nicely. And so we were able to really use their expertise and their knowledge from navigating these systems to identify partners that we wanted to work with, identify partners that we needed to put some added supports there so they can support the community in a more appropriate way. And so it was really key and instrumental in how we shaped our programming and where we needed to start first. And so we do that community needs assessment and that ongoing review of our community needs. And then from it, we definitely discovered some things that we already knew already. But something that is key for the SPA 6 community is that we have a larger population between the ages of 18 and 64 than any other SPA. And so that was really key for us about where to target, how to target, and what we needed to do to adapt maybe some of our interventions based off the population that we're serving. What we knew as well is that African American students are facing stronger disciplinary action within the schools than other groups and their counterparts, as well as those out of school, I already said that, the out of school suspensions and things like that, but also the graduation rate is impacted as well. I'm sorry, you guys. I had a new coffee today. I'm still adjusting to the caffeine. And then as well as our community, those social determinants of health, we see the increased exposure and or barriers related to social determinants of health within our community. And highlighted throughout our presentation, just the lack of culturally and trauma-informed care. So again, a lot of the things were aligned with some items that we knew already, but to hear that that is what our community was actually experiencing was beneficial to know that we were on target, but also let us know that there's still a lot of work that needs to be done because these are still identified issues.
Okay. So within the CCBHC model, the first step was we really needed executive management support. That was crucial. It's a big shift in streamlining processes. So it's a lot of policy creation up front, a lot of just making sure your system flows from one person to the next. And so executive management was extremely crucial during that. And we had the ability to train across all of our programs. Every staff gets a suicide prevention training with a connection to resources. Just understanding that many of our programs aren't run by clinicians. Many of them are run by community members, those with lived experience. And so giving them that suicide prevention training was essential to this model. We do use hopelessness as an indicator for suicide prevention, just with our community that we're serving, understanding that hopelessness is a better indicator than some of the more mainstream indicators, and as well as like ability to plan for your future. So with that, employment opportunities also expanded during the CCBHC model. QAQI, we were able to hire a QAQI administrator and then also just increase our QAQI team. We hired an evaluator and a research analyst to support with all of the data collection and then just the amount of reporting out. Also being able to use that data to inform our services. We hired peer support specialists and care coordinators. Those are all individuals with lived experience who are from the South LA community. And they're really a person's first point of contact. So it helps participants just feel welcome, and they set the participant up for success. So if they need to apply for Medi-Cal up front, or if they need to arrange for transportation up front, that the peer support and the care coordinators are kind of helping with that. We hired an additional transportation worker who's full-time van driver and can support with navigating different appointments. So part of the CCBHC model is medical care and just ensuring that people have quality medical care. And so our van driver can transport to medical appointments as well. We increased our child development services. So every location has a child development staff and program there. So wherever a family comes in, they're always going to have access to child development where they can put their children somewhere safe and fun for the kids as well while they kind of focus on the needs that they have. And then we hired a community engagement liaison. For staff trainings, we retrained all of our staff to ensure that we have the mandated reporter to community supporter training, just following the state mandate for the AB 2085. We increased evidence-based practices. So all staff are trained in one evidence-based practice at minimum, but we increased DBT as one of the practices for adults. And then our grid for training, for annual training is just, I want to say tripled, but there was a focus for sure on veterans that was new for us. And so our staff really required additional training around working with veterans.
Right. And so, yes, so that training both internally and externally. So for sure, our staff to have that opportunity for those extended trainings, though our list may be intimidating upon hire, it is a great opportunity to ensure quality services are being received within the community. And so it is a good check and balance to ensure that we are providing that quality of care that our families need. And again, with that research piece, being able to go against that data and that community feedback from our consumer advisory, they're letting us know if we're doing good work or not, or if we have areas for growth. For our internal agency support, so really just streamlining and crossing over to ensure that all of our programming aligns and supports our identified families. And so specific to African American families, our vocational and educational services, like Christina highlighted, building those into the actual program. So individuals do not have to find childcare, go to multiple places. They can just go to a one-stop shop, receive their educational and or vocational supports. We have child welfare support. We are co-located in children's court out here, so we can support our individuals within the courtroom setting, as well as community members have access to those supports. For our PPW, we have family preservation, our Welcome Baby, Parent as Teachers, Healthy Families America, Healthy Start, and Child Development to support with really that 0 to 5 need. We have a community cultural broker pilot program, which specifically supports African American families. The only requirement is to be African American and have children. They are attached to someone to really just provide navigation and support, whatever it is they need. They really are, the staff are on demand and really support those families. And then our FFPSA expansion, being able to expand those FFT and MST services, as well as PAT and home visitation. And we are really excited about our newest pilot, which is our plans of safe care and preventative legal support. So again, really that focus of keeping our families out of the system and doing wraparound support services. Thank you for outlining what FFPSA stands for. And then going on, so really building those sustainable partnerships. So like Christina identified, those medical partners. So we partner with Claris Health that focus on sexual reproductive health for our families. Choice Health, which is primary health care. We are actually in the process of opening a satellite clinic within one of our buildings. So our families, once again, do not have to travel anywhere. They just walk into treatment and can receive services, them and their children. So the provider comes on site and provides all of those medical supports. Of course, if there's referral out, then we do support the transportation to those referrals. And then our lab partner who provide our UA and or any blood work required for our participants, so they have that holistic care, and they really have that cultural and trauma informed medical partners working with them. Our educational expansion, so we are already within about 80 different schools within SPA 6, but with our CCBHC expansion, we were able to highlight and focus on 2 schools that had the most enrolled African American students to provide on-site supports to those families. So expanding our individual and our EBP, our evidence-based practice model, so MST and FFT services to the families and on-site at the school, as well as with the educators. And then just our overall community supports, we were able to partner with the American Foundation of Suicide Prevention to train all of our employees, as well as provide those supports. Through our Cal Hope program, we have Saluna and Bright Life, which everyone has access to as well. And then with LADO, our Los Angeles dependency lawyers, as well as Compton Courthouse, Hope Court specifically. So a lot of preventative work being done with those partners and continuing to expand on those through CCBHC.
And then part of identifying the partners through the community needs assessment was to choose partners who were willing to allow us to cross-train a little bit, so that we can ensure as we refer our clients that they're going to be handled with care and that they're going to be in a safe place as well. And so from our schools, we targeted schools that have at least 10% African American, but they also have the Black Student Achievement Plan through LA Unified. And with those schools, we cross-train on trauma-informed care as a 6-part series for educational staff to just equip the educators on really how to navigate trauma in the classroom and really prepare for those conversations to make sure our students are being treated in a way that they deserve to be treated in the education system. And then for cross-training for our medical partners, we provided the mandated supporter to community supporter, mandated supporter and AB 2085 training. Just to make sure that we're all aligning with our goal is to prevent people from involvement in systems. And so we don't want to refer to a medical partner that then they end up catching a DCFS case for. So just ensuring that as long as somebody is safe and long as the children are safe, then we can provide the preventative services. So we provided that training, and then our medical partners consult with us if there is any red flags that are raised, and we kind of create safety plans around that. We offer professional development specifically to the school staff. So we just facilitated one on navigating difficult conversations. One of our school partners identified like a lot of racial conflict happening at their school site. And so our training focused on just equipping educators for navigating conversations with students. And so whatever the school needs that they're identifying as, oh, this is becoming an issue at our school site, we create training around that and offer professional development. We offer caregiver workshops as well. So we do identifying mental health needs in their children. Substance abuse awareness is very, very popular with our caregivers. And so we offer that at every school. And then healthy communication between parent and child, just to ensure the children feel comfortable sharing with their parents and parents are open to receiving information. And then student workshops focusing on healthy relationships, and then mindfulness in the classroom to help students with their regulation in the classroom. So we offer that training throughout our partnerships and just ongoing as needed.
Nice. And then our main support as well, our key supports would be our consumer advisory board. So those two different layers, we have consumer advisory boards specifically for our substance use programs. And so they provide that direct feedback to us on a monthly basis regarding how their treatment is going. Are there any areas of growth? What are themes that they're seeing within the community, within systems? So then we can create plans to address those. And then with our CCBHC, we have a greater community consumer advisory board. And so they meet monthly. They've had 10 meetings so far. They have named themselves warriors of the community. And so we have 16 members in total. They have built up a waiting list. We're so proud of them. They have a waiting list of consumers that would like to participate in it. And so they're developing a plan for ways to volunteer. But they really guide us for our overall, what do we need to do? How can we improve? Again, just what systems do we need to address and work on as providers? And so our QA staff is also a part of that. They sit within the meetings. And so whatever notes that the community members provide, they bring that back to us as leadership. So we're able to then review our policies, review our partnerships to make sure that we're incorporating their voice and their needs overall. And then we are doing that cross-training as well. It is one thing to train providers, but our community members need to know all the changes within the systems as well. So providing that mandated supporter training to them as well. So they're informed with AB 2085. So they can hold us as systems accountable for providing the care and or supports that they are required to receive and should expect to receive from us. And then, oh, look at us, we did it. We're to the end. So we're gonna leave time for questions and stuff, but we're gonna put this all together real quick. And so just really moving into just our overall highlights and themes and what, really starting off with Shields as our core and that family-centered treatment model as our lens and our practice, and then incorporating CCBHC has really just amplified our ability to be culturally and trauma-informed and providing care that is really guided by culture and the impact of trauma within our communities to ensure that we really are truly addressing the needs of our families and not the needs of providers. And so with all of our increases, we have started, it's really early, but with the data that we've collected throughout these past 2 years, just really seeing having those culturally informed partners, the willingness of our families to really go engage in preventative medical care. And so we've seen an increase there with our families, seen an increase in trust in, hey, we need lab work done for your psychiatric appointment, and an understanding to say, okay, I know my blood is not going anywhere else. This is the purpose it's being used for. It's really to support me. And so we really have seen less quote unquote resistance with engaging in some of those medical practices that we've seen. Really reducing that disproportionality. We still do have a lot of work to do. That's why we're all here today or the next 2 days. We're really supporting our families with wraparound services, preventative services, training those systems so they know, hey, these are the preventative services available within your community. So you do not have to call child welfare if there can be supports put in place for a family. And then just overall sustainability and long-term for us, just finding ways and creating ways to ensure that we can continue to provide these services within the community. Those are key. A lot of our communities that are typically marginalized or face greater disproportionality have an unfortunate history of people receiving grants, coming into the community, and then going away because they don't have a long-term plan for services. So sustainability and long-term funding and figuring out ways that we can build in all of these supports ongoing so our community can continue to have that trust with service providers overall. And I think we did it. Thank you guys. We appreciate you. If there's any questions, comments, please feel free. We are here for a couple more minutes.
Right, till 12:15.
12:15.
Feel free to come off mute and ask questions. I know I have a few, but I want to wait for them.
Okay.
Hi, Claudia from Sacramento. I just had a comment. You guys are doing phenomenal things out there in Los Angeles. That program is awesome. Hopefully, somehow we can maybe get a prototype and maybe mimic some of those things out here in Sacramento. Those wraparound services. And it's not that you guys are just providing the services, you're making sure that hand to hand is actually being done. It's the accountability, because that's where most times clients and people, regular people, are getting lost. We know where the services are, you know how to get them, but then who's making sure that I receive them once you assess me and put me into this system now? And I love how you guys are almost being like a proactive instead of reactive. Like you're making sure that maybe that program is available so that you don't have to enter a system just to be allowed that access to the program. The program is there before to avoid maybe a person getting into any system. So phenomenal work, guys.
Oh, thank you. And we would love to connect. We appreciate you.
Yeah. You also said our motto, like Danielle and I are proactive, not reactive. So we drill it into our staff too. So we appreciate that recognition a lot.
I had a question just because I neglected to introduce myself earlier. I'm Barbara DeGraff from Strategies TA, and I actually work in El Dorado County and rural counties up in the northern part of the state. I'm in South Lake Tahoe, and I'm also a CASA in my community. And one of the things I see over and over, which really intrigued me when I heard you all, was this idea that treatment can start right away, because I hear people over and over say the same thing, that they're ready and then there's no services available for them. And then, weeks go by, a long time. And then by the time people re-engage, the person's been lost to the system. So how do you make that happen in a huge area like that?
That's a great question. I mean, it's really just been to set up our model. So our amazing program specialists, administrative assistants, they are like our lifeline in all of our programs. They never not answer a phone. They never not answer those referrals, and they meet the families right then and there. And so we've really set up that structure with our admin assistant and as well as our client counsel located at the program. So if, let's say, the counselor is not available to do that intake right then and there, the president or vice president of the client counsel really takes on that role and that leadership to really engage the individual coming into services, just to really provide that encouragement and really that brother, sister, or sister model to ensure that they have like that peer support of someone who is on that sobriety journey, who remembers that first day walking in and what that felt like, and are, now 3 months, 6 months in sobriety. So it really just, either way, whatever the touch point is, it really is just about engaging and someone capturing them. But all of our staff are trained with the understanding that I don't care if you're facilities, therapist, program manager, everyone needs to be available to engage. Like, that's an expectation across the board. It's not role specific.
Excellent.
And I will say, just the understanding that it took so much for that person to even get through our door,
Yes.
we're not going to let them walk away with nothing. And so sometimes it is a lot of pro bono work, and the agency just has to be okay with, like, yeah, we're just doing this for free right now, but it's so crucial. And so I will say our team at Shields really supports us in that. And like, yep, some of the services we're not going to be able to get reimbursed for, but that's fine. Like, this person needs it right now, and we're going to figure it out later. And so that's really, really helpful. And then also the care coordinators just being a first touch point. If we can't get a therapist right away or a SED counselor right away, that person will keep them connected. And so we at least make sure that they get connected to something, because just to walk through that door, they had to go through so much. And so we don't want to turn anybody away because of that.
I think if I can chime in, and I apologize, I can't figure out how to raise my hand.
It's okay.
Don't worry, we're free
I'm
now.
sorry.
I wouldn't
so
have known
far
how
in.
either.
Goodness, it's like 4 years in, I can't figure it out. Agree with everything that folks have said, and in the chat, I think what also was striking to me as I listened to you was dignity and the dignity that you are extending for human beings in the world who are struggling. I mean, even as you described, like, do you need coffee? Like, we live on caffeine. Are your kids fed? Like, all of those pieces that I think, and what you just said about like how hard it is to walk through a door, right? And then what you receive on the other end of the door. So when you like worked so hard to walk through that door, if what you're received on the other end with is abrupt and not like how likely are you to stay? So just thank you for that, because I think that dignity just came through and through in the way I felt like I could feel how families are experiencing walking in, and was grateful for that. So thank you.
Thank you.
And our families will definitely name when they haven't been treated with dignity.
Oh,
Like,
yeah.
I walked into this site and they didn't, you know, so
Right.
they'll for sure let us know.
Absolutely. And then we call, hey.
I was gonna say, I love that because they trust you, right?
Yeah.
They're like, yeah.
That's exactly right. I was going to say that because people are afraid to do that. They're afraid, in my community in particular, it's such a small community, you know, you make somebody angry and then, you know, you're not getting anything. So that's that trust that you've built up that's so important. And I love that consumer advisory board. And I made a note for our planning team to have them do a presentation in the future to talk about
Awesome.
their work, because I think that would be awesome.
That'd be, yeah.
That would be amazing.
Yes. They would love that. Look, they already even made t-shirt designs.
I
and-
love it. I love it. That people want to be a part of it. And
Yes.
it's voluntary, no pay for them.
Well, we give them food, of course. You know, you
Okay.
have to always give people food.
Right.
But,
Yes. Yes.
other than that, they volunteer. We do actually, I lied. I apologize. We do give them gift cards for their time.
Yes. Yes.
But
You
they're small
compensate. Mhm,
tokens.
mhm.
They're about $25, gift
Right.
cards of their choice, and then we feed them. But I think the fact that they actively see their work and their voice being done, they're like, oh, let's do this. Let's do, and they help us with our events. So they do the volunteer work and help us with recruitment and outreach. So they have really owned it.
That's great. That's hard to do. That's really hard
Yes.
to do.
But also we do it through the lens of this is resume building too. And so
Yes.
that is definitely an activity that we support them with adding on to their resume as, sometimes first customer service, experience with individuals. And so definitely provide that and let them know like, hey, this is going to push you up, your
Right.
application.
Exactly.
Mhm.
Yeah. Yeah. Maybe connections.
Absolutely.
Right. Any other questions for our wonderful presenters? If not, we'll give you an extra 3 minutes for your lunch. So here's what